and gentlemen, on behalf of the entire BSV team, I extend a very warm welcome to all of you to the lecture series on intrapartum care. Over 5 decades now, we at Bharat Serums and Vaccines have developed and commercialized innovative biological, biotech, and pharmaceutical products through cutting edge research in the areas of women's health and IVF. In our continued endeavor for excellence and service to mankind, we bring forth a lecture series on intrapartum care, which focuses on safe delivery practices. There has been substantial increase over the last couple of decades in the application of a range of labor practices to initiate, accelerate, monitor the physiological process of labor with the aim of improving outcomes for women and babies. To enlighten us further on the topic, we have with us a very senior veteran, practicing obstetrician and gynecologist, respected Dr. Ranjana Khanna ma'am. She is currently senior consultant, director of Ranjana Hospital, Prayagraj. She has been past vice president of Foxy, and she has been founder president of Indian Society of Perinatology and Reproductive Biology, Prayagraj, and has many more accolades to her credit. Without further ado, I welcome Dr. Ranjana Khanna ma'am.
A very good evening. Oh, I haven't. Can you put on the presentation? Can you put on the presentation?
Prasad, do you
Yes,
have
ma'am. Yes, I'll share.
Actually, I forgot to upload it. Should I do it? Let's see. Should I do it? It will take me just 2 minutes to go out, and then I just hope I don't have problem in coming in again.
No, I'll share it, ma'am. Just a minute.
Okay. But then I won't have the moving rights of that, no? Will I?
Yeah, then we'll wait, ma'am, for a minute.
So should I take it?
Yeah.
Okay, just a minute. Minimize कर लेता है. Because how will I get that? Yeah. Yeah. Is it okay?
Not visible, ma'am.
on a topic which is extremely close to my heart, intrapartum care. I have been a die-hard obstetrician for the last around 45 years. And even when I was doing my PG in GSVM Medical College, Kanpur, from that time onwards, I have been continuously been an obstetrician and delivered patients. And we have done a large amount of normal deliveries. And Epidosin has always been one of my favorites. And I will talk more about it as we proceed in this topic in this webinar on programmed labor. So, active management of labor was a concept which was advanced by the Irish school. In 1973, O'Driscoll and his colleagues reported on the advantages of active management of labor, resulting in shorter labors, improved obstetrical outcome, and of course, a reduction in the number of cesarean sections. What are the advantages of active management of labor? Why do we talk about it? Active management of labor is necessary to prevent infection in the mother, dehydration, ketosis, exhaustion, delusions in the mother, and fetal distress. So, this is a picture showing the normal partogram. And we know that this is the normal partogram, and the more it shifts towards the right, the more is the prolonged labor, and we will have to intervene once it goes to the extreme right to the action line. So, how do we select our patients for this active management of labor, which is also known as programmed labor? No identifiable medical or obstetrical complications should be present. Primi gravida with singleton pregnancy with cephalic presentation with spontaneous onset of labor, but it can be a multigravida too. Gestational maturity 37 to 41 weeks of gestation. On admission, the NST is reactive. Active phase of labor with cervical dilatation 4 centimeters and 50% effaced. That is very important. So the selection criteria is it could be a primi or a multi, more than 38 weeks of gestation, low risk patient, there should be no complications. The presence of an anesthetist and neonatologist is very, very important. Consent of the mother is there, should be there, and it is always done during the active phase of labor. So first stage of labor, first is the latent phase up to 4 centimeters dilatation. It takes around 12 to 16 hours. And in that phase, we will not intervene. But once the patient steps into the active phase of labor, it is then after 4 centimeters dilatation, when the cervix is partially effaced, when the membranes are mostly present, show could be there. And that is the time when we would want to intervene and conduct the programmed labor, because that is the time when the pains also become more intense, and the patient definitely needs some form of analgesia to relieve her of that pain. So patients not to be considered for intrapartum care, or should we say active phase of labor, active management of labor, would be high-risk cases like APH, preeclampsia, diabetes, poly and oligohydramnios, CPD, malpresentation, and PROM. The medication protocol for interpartum care begins when the patient enters the active phase of labor. We have talked about this. The starting point of active phase of labor is identified on basis of clinical evaluation when following parameters are satisfied: cervical dilatation 4 centimeters or more, cervical effacement more than 50%, uterine contractions come at a frequency of at least 3 per 10 minutes, and they last for 35 to 45 seconds. The head should be engaged. There should be no suspicion of CPD. Patient may have show or slight like a discharge. The medications which are used in active management of the active phase of labor: As per protocol, a combination of drugs are used to provide effective pain relief, coupled with antispasmodic drugs, which help the cervical softening, yielding, and dilatation to moderate the driving forces. What are the advantages? There, because we are using a combination of drugs, so what happens that they have synergistic effect on each other, and because of that a lesser dosage of each drug is required. So because of this, the patient or the baby does not have any adverse reaction. There are no side effects of the drug because we are using it in such low doses, but because their analgesic effects are being synergized with each other, that is why a lower dosage is required, and it safeguards the mother and her fetus against any major drug adverse effects. So what do? We start an IV drip with 5% ringer lactate solution at the rate of 20 drops per minute. Ensure that the pains are optimal, that is 3 to 4 pains per 10 minutes. And if you find that the pains are slightly less, you may add 2 units of oxytocin to the drip, or we can give misoprostol 25 milligrams every 1 or 2 hourly to ensure optimal pains, which will result in progressive labor. So dilute. Now, how do we give the pain relief? So you dilute 1 ampule of 30 milligrams of pentazocin with a diluent like normal saline or distilled water, and similarly you dilute an ampule of diazepam in 10 ml of the diluent. Now, what you have to administer is just 1/5 of this dosage. So, 1/5 of 30 milligrams would be 6 milligrams of pentazocin, diazepam 2 milligram. You give them together in a bolus through the IV tube, and they act synergistically, and wonderful analgesia can be achieved without any respiratory depression, which could be there if we had given the full dosage, but we are giving very low dosage. So observe the progress of labor by charting maternal and fetal parameters every hour or earlier if indicated, and assess the progress of labor on basis of cervical dilatation and descent of the fetal head. And we have to record it periodically on the partogram. When the patient is now in the advanced labor and the fetal head is pressing down on the pelvic floor, the patient is in excruciating pain. Cervical dilatation is 7 to 8 centimeters. She has a bearing down sensation, but the cervix is not dilating. She is in a lot of pain. This is the time when you have to administer injection ketamine if required. And what is the dosage of ketamine? Injection ketamine is given in a dose of 0.25 to 0.5 milligram per kg body weight. Dilute the drug in 10 ml saline and give it IV slowly over a few minutes till the desired effect is obtained. After a small dose of 0.25 milligram per kg, normally it suffices, that is sufficient. So for example, if the patient is 60 kg weight, 15 to 30 milligrams of ketamine is enough for pain relief. We can give top-up doses after every 20 minutes to 30 minutes, and that should be half of the original dose. So like if you have given 15 milligrams, initially you give 7.5. If you've given 30, you can give up to 15 milligrams. And the last top-up dose you would like to give after the patient has delivered the baby. Why? Because then the pain will not be there and she will let you examine her genitalia comfortably. So this is the way in which ketamine should be administered. And another drug which we give anesthesia during labor, the proven obstetric analgesia, is epidural anesthesia. In places where epidural cannot be provided, tramadol A centrally acting non-opioid analgesic has been used as a labor analgesic. But ketamine, a dissociative anesthetic, is now gaining popularity as it provides excellent pain relief and patient satisfaction. Is there any drawback of ketamine? Yes, I have seen in one or two patients that often there are some hallucinations. The patient starts hallucinating. So often what happens is that the patient is, if she is having nice hallucinations, she is laughing, she's comfortable. But sometimes she starts screaming uncontrollably. That is because of these hallucinating effects. But that is not in every patient. It is, I have, in all my practice, I've seen it only in 2 patients till now. And level of analgesia assessed is using the following scale: no pain relief, 0, 1 is mild pain relief, 2 is moderate, and 3 is excellent pain relief. Now, another thing that we use for pain relief is injection tramadol 1 milligram per kg plus an antispasmodic of a choice for which really helps in cervical dilatation, and that is Epidosin. We'll come to this. Now, the clinical evidence, there was this study which was done on study group 200 with programmed labor, and in 200 were the controls. So it was seen that vaginal delivery in the programmed labor group was 176 of them had vaginal deliveries, 162 in the control group, and spontaneous unassisted delivery was practically the same in both the groups. Forceps and ventouse were needed more in the control group. LSCS was 38 as opposed to 24 in the programmed labor group. And the mean duration of active phase of labor was 3.5 hours in the programmed labor, and in the control group, it was the tune of more than 5 hours. So mean rate of cervical dilatation, 2.5 centimeters per hour in the programmed labor group, as opposed to 1.2 centimeters per hour in the control group. Mean duration of second stage of labor, 26 minutes as opposed to 48 minutes. And third stage of labor with average blood loss was 3.5 minutes only in the programmed labor and 15 minutes in the control group. So pain relief was excellent, of course, in the group with programmed labor because we have been giving analgesics, and analgesia was not administered in the control group. So obviously they had pain. The rate of cervical dilatation, I have said that in the case of, it was 1.72 centimeters per hour. In the ones with antispasmodics and controls, it was 1.23 centimeters per hour. There was statistically significant difference in the duration of second stage of labor. Pain relief was better in the study group as compared to the controls. But the nausea, vomiting, drowsiness, tachycardia, hypertonic contractions, cervical vaginal tears, and rupture uterus was not there. But besides that, the side effects observed were more in the controls because they were on drugs. So we can say that the rate of cervical dilatation was 1.72 centimeters per hour in the programmed labor group and 1.23 centimeters per hour in the controls, which is statistically significant. The duration of active phase of labor was significantly reduced, 3.45 hours in the cases and 4.78 hours in the controls, again statistically significant. Duration of second stage was 27.4 minutes in the programmed labor and 34 minutes in the controls. Majority of both patients in both the groups delivered vaginally. 86% patients in the study group had pain relief as compared to 22% in the control group. The cases had significantly more drug-related side effects like nausea, vomiting, drowsiness, and there were no significant fetal or neonatal complications in either group. So now we talk about the use of antispasmodics, and they saw that the antispasmodics reduced the duration of the first stage of labor by an average of around 1.5 hours. And it was seen that when you're using antispasmodic, the mean duration of the first stage of labor in the intervention groups was 74.34 lower, and the mean duration of the second stage of labor in the intervention groups was 2.68 lower, and in the third stage it was 0.06 lower. The mean total duration of labor in the intervention group was 85.51 lower, and the mean rate of cervical dilatation in the intervention group was 0.61 higher. Now, evidence on epidosin. Before we move on to the text, I would like to say that epidosin is an anticholinergic drug. It acts, see, the acetylcholine is the one which helps in neuromuscular transmission, and this is anti-acetylcholine. So it is an anticholinergic drug, and because of that, it prevents the transmission of pain from the nerves to the muscles. So it causes relaxation of the muscles and causes cervical dilatation to take place. We have personally used epidosin for hundreds of deliveries, and we always gave it around 5 centimeters dilatation when the cervix was around 60-70% effaced. Membranes had to be present for it to be effective, because we often used it in absent membranes but found that it was not efficacious. And we gave it in the doses of 1 ampule every half an hour for 3 ampules. That was the total dose we gave. And we found wonderful results and very quick and efficacious dilatation of the cervix, which followed. But often, in some cases, if the patient was already in very prolonged labor, then we also gave it after every 15 minutes. But we gave it to only 3 doses, though we can actually increase it to up to 6 doses. But 3 doses would often suffice. There was this patient of mine. She was in prolonged labor. She was a primey, and the pelvis was very good. There was no CPD. The head was deeply engaged, and the labor got arrested at 6 to 7 centimeters dilatation. It was very frustrating. After 1 hour, I reassessed the patient and found that still the patient was 6 to 7 centimeters dilated. So I just gave 1 shot of epidosin, believe me, just 1 ampule, that is 8 milligrams of epidosin. And I told the nurse to repeat it after half an hour. But the time did not come, because after 10 minutes, when I was planning to get a second shot after 15 minutes, I found that the head was already at the perineum. She was crowning and she delivered beautifully, uneventfully, and the delivery was so nice. And the patient kept on thanking me for the injection that I had given her, which caused her to have such quick and rapid and easy and simple delivery. So this was the effect of epidosin, not on 1 patient. I'm just telling you that in this patient, I only had to give 1 ampule. Otherwise, we used to give 3 ampules. And by the time we ended up with the third, the patient was almost in full dilatation. So this was the beauty of this drug. The only once in 2 or 3 patients, we noticed, however, that sometimes, the pains would go down a bit. The uterine contractions would go down. So if we had not kept the patient on any drip, then we would start a drip and give oxytocin to pep up the contractions a bit, because as I have told you earlier, that it is antispasmodic drug. So naturally it will relieve the spasm, but beautiful dilatation of the cervix, and we can really cut short the labor very effectively with this. So this comes under the group of anticholinergic drugs. And this is a synthetic compound, and it comes under tertiary amines. So dicyclomine and valethamate bromide. This is the actual name. Uses of this anticholinergic smooth muscle relaxant is to hasten dilatation of the cervix when the same is delayed during labor, and as a visceral antispasmodic. 8 milligrams IM repeated as required, and epidosin 8 milligrams injection is given. And we can also give 2 milligrams stat, 2 ampule stat. That means 16 milligrams can be given stat, or we can give in even IV. Nowadays, they are recommending that we give 2 ampules, that is 16 milligrams IV stat. But I don't have personal experience of using it intravenous. We always gave it intramuscular with beautiful response. So numerous drugs, there was this study which was done, and numerous drugs have been used to shorten the active phase of labor. And but there are several drugs, but do they really shorten the duration of the active phase of labor? Does it have any adverse effects on the baby and the mother? These questions were the basis to perform the present study of comparing 2 such drugs, injection rotavirin and injection valethamate bromide, that is epidosin, with the control subjects. This was a prospective study conducted in a tertiary center over a span of 2 years. 120 patients were enrolled in the study group. These patients were randomly allotted in 3 groups. 60 patients, 30 gravida and 30 multi, control group, no drug given. And in 30 patients, 15 primary and 15 multi, rotavirin was given. And in 13 patients, 15 primary, 15 multi, valethamate bromide was given. And it was found that the rate of cervical dilatation was significantly higher compared to the control group. Now, this prospective, there was another study which was done, aimed to investigate the effect of valethamate bromide on the length of labor. A single dose of 16 milligrams valethamate bromide was administered via the intravenous route in randomly selected 35 nulli and 37 multiparous women. The median time from complete cervical dilatation to the delivery was 20 minutes in the groups received valethamate bromide and 25 minutes in the groups that did not receive this drug. Median time from complete cervical dilatation to delivery was 20 minutes in the groups that received valethamate bromide and 25 minutes in the groups that did not receive this drug. So it is seen that valethamate bromide significantly shortens the second stage of labor in nulliparous women. The side effects are not statistically significant in the valethamate bromide group versus the placebo group. So there are no side effects, and in my years of practice, I have not encountered any adverse effect on the mother or the fetus of injection valethamate bromide. So it is a valethamate bromide, and believe me, it's a wonderful drug. No statistical significance was found when the adverse drug reaction was compared between the age group of 18 to 25 years and 26 to 35 years. Therefore, the adverse drug reactions reported were irrespective of the age of the patients, and no life-threatening or severe forms of drug reactions were seen with hyoscine and valethamate during cervical dilatation. And there were several studies which compared rotavirin versus valethamate bromide. And what did they find? They found that headache and cervical tear were less in the valethamate group as compared to the rotavirin group. So we can say one thing, that the use of epidosin really helps the patient. And in fact, we often gave it to patients who came to us directly in the active phase of labor, where we saw that the labor may get prolonged. So we found it very convenient to give 3 ampules of epidosin at half-hourly intervals. And we found wonderful response. And in case we realized that the contractions had slowed down a bit, we would add on oxytocin drip. and conducted beautiful normal deliveries without any problems. And really the incidence in those days of the cervix LSCS was much less, and we were rather disheartened actually when Epidosin got discontinued. So now it gives me great pleasure to see that it has come back again. So what are the advantages of this intrapartum care? It shortens labor with substantial pain relief, significant amnesia of the painful events of labor, average blood loss was less, duration of all 3 stages of labor was markedly reduced, and obstetrical management becomes simplified, lowering of incidence of operative deliveries, and neonatal mortality is similar to the control group. So I would say a thank you. And before I finish, I would request you all to give me your vote and support as I stand for Foxy President in election year 2024. Thank you all so much. So any questions?
Thank you so much, ma'am, for the lucid and the detailed presentation. And I'm sure it has helped all the audiences. It has given audiences a lot of insights to their practice. So we have actually a lot of questions pouring in. And uh, I'll take up the first question.
Yeah.
This is question from Dr. Shantanu. He says, he asks whether it is actually necessary to intervene the process of labor, which is a physiological process, with drugs.
Yeah. See, I would love to answer this question because I had a conference, a national conference, Foxy conference just now on 15th, 16th, 17th of December. And on 15th, we had this workshop on art of natural birthing. So we had a team of doctors who came and demonstrated. And, actually nowadays, the government is focusing on natural birthing. They say, don't give medicines, just let the patient be and let her deliver in whatever posture she wants to deliver. If she wants to deliver in the sitting posture, let her do that. If she wants to deliver in the standing posture also, she can deliver semi-recumbent, whatever posture she wants, she can take up. But what happens is that I was discussing with the British midwives because they were also connected with us during the conference. So I just asked them that the way you all are conducting deliveries, like not supporting the perineum and all, and doesn't the patient get exhausted sometimes and give into tears, perineal tears? So they said that not much seen in the Western world. But in India, the anemia incidence is so high that the patient often goes into prolonged labor. The women who are coming for delivery, they have 8, 9, hemoglobin, and their 11 is anemic. So 11 over here, we are very happy if the patient has 11 grams. So you are right, Dr. Shantanu, when you say that we can leave the patient, let it be. So in the initial phases, in the latent phase, we are letting the patient be. It's in the active phase when we see that the patient is moving towards prolonged labor that we want to intervene. So that is the time when the patient gets impatient and she'll start saying, Acha, you do anything, you do a cesarean, but take out the baby. So just to avoid that, that is the stage when we want to step in and do this active management of labor. Otherwise, as you say, if the patient is progressing good on her own, we would not like to interfere.
Right. So I'll go to the next question. Next question is from Dr. Muskan. She asks about what are the different drugs that are used for hastening the labor.
Well, that depends on which stage the labor is arrested and what is the reason. So if it is because of inadequate contractions, We can use prostaglandins and we can also use oxytocin. But if it is because of cervical dystocia, cervix is not dilating, then in that case, we would love to use epidosin, that is valethamate bromide, that can be used, and that will effectively dilate the cervix and bring about the actually delivery, because the valethamate bromide itself will cause the quick dilatation of the cervix without any harm. Believe me, there's no harm to the mother, there's no harm to the fetus, except for a bit of dryness of the mouth. There's no harm whatsoever. We can safely give epidosin. I have given many a time whenever labor gets prolonged, starts getting prolonged, and the mother starts getting exhausted. When the mother is exhausted, we have to resort to these drugs. For cervical dilatation and for inadequate contractions, it will be oxytocin or prostaglandins.
Thank you so much, ma'am. I'll move on to the next question. So this question is from Dr. Nikhil. He asks, what is the dosage of valethamate bromide? At what dose do you, how do you administer, and how many doses total can be administered? Ma'am, you are on mute.
The dosage which we administer is 1 ampule of valethamate bromide, that is 8 milligrams, is given after every half an hour, and we give 3 doses. But maximum of 6 doses can be given, though I have basically used 3 doses always, and it can be given at half-hourly interval. But sometimes, if the patient was very exhausted and the labor had gotten arrested, then I also have used it after every 15 minutes for 3 doses. Though nowadays they are recommending IV, and they are recommending 16 milligrams IV. But I have personally not used IV. We have always used intramuscularly with very good response.
Thank you, ma'am. We have another question from Dr. Anjali. She is a PG student at MKCG Medical College, and she asks, is there any standard protocol?
Of what?
Of active management of labor, of drugs that one needs to follow, because there are, in practice, there are a lot of differences in practice. So is there any standard protocol that exists, and what should be the line of thought?
Yeah, the standard protocol is sometimes if the contractions are inadequate, then we'll start initially with the low dose of oxytocin and then step it up. And but when we are talking about programmed labor, it's about giving joyful maternity care. So we want to relieve the patient of the pain. Then those dosage, I've already said that we will synergize 2 drugs together. So it is pentazocin and diazepam. So 6 milligrams of pentazocin and 2 milligrams of diazepam are clubbed together and given intravenously. That will relieve the patient. And if we want, we can always give a top-up dose, but it's normally not needed. And then to hasten the cervical dilatation, and if the patient is still having pain, we can give tramadol injection. See, tramadol is in the group of pethidine, but pethidine is not recommended because it causes respiratory depression in the mother as well as in the fetus. And so we can give, however, tramadol can be given safely. So we can give tramadol along with epidosin, that is valethamate bromide, and that can be given, and just give 3 injections. It will relieve the spasm also, and it hastens delivery.
Okay. Thank you, ma'am. We have another question from Dr. Jyoti. She asks on the role of epidural analgesia. Which epidural analgesia is given, and if you could further throw some light on it.
Yeah, epidural analgesia is very much used in the Western countries, and they, after the anesthetist gives the injection, she puts in an epidural cannula, and from that she keeps on giving the drug, the lignocaine. So that sort of sensitizes it, anesthetizes the lower part like we do in a cesarean. So there are several advantages of this. If you have to switch over immediately to a cesarean, so just immediately switch over to a cesarean, because the patient is already anesthetized. She's actually, it's epidural analgesia, or you can say epidural anesthesia, because but the repeated pricks don't have to be given, because per se epidural anesthesia will not last more than 2 to 3 hours. But if we put in a cannula and keep on giving small top-up doses the anesthetist gives, so that will maintain, and there will be no pain. In fact, the patient will be told that now crowning has occurred, so you bear down. If she won't be able to bear down, then often a forceps has to be applied to take out the baby, because all the nervous system is, anesthetized. So she is not able to utilize her muscles properly. And so that is a very good actually method. It's one of the safest analgesia as well as anesthesia. So suppose fetal distress occurs or some such problem occurs, immediate cesarean can be done.
Thank you so much, ma'am. We have another question from Dr. Nupur from Bombay. She asked on role of Kegel exercises in labor, healthy normal delivery.
Yeah, actually they have a very important role. Kegel exercises have a because they will strengthen the muscles of the perineum. And like that British midwife was telling me, that we don't have much incidences of perineal tear, even though we're not giving much support. Like in the sitting posture, if she's delivering, it's difficult to give perineal support. So they said ki we don't have, because probably the muscles are stronger and healthier as opposed to our Indian population. So that is probably because they lay a lot of stress on these Kegel exercises and, strengthening of the perineal muscles, which is very important. And it's done in the antenatal period. So it will be very important.
So are they recommended in postnatal period as well for recovery of the muscle perineal?
Yeah.
So Prasad, do you have any questions coming in? Some more questions?
Actually, I think majority of the questions you have already answered. Dr. Anandita asked many questions. I think I'm not seeing any further comments here, further questions here.
Thank you so much, ma'am. Prasad, over to you for the vote.
Yeah. Thank you, Dr. Anandita. First of all, thanks a lot, ma'am. And thank you for the showing the trust on Epidosin. That gives us more confidence here. On behalf of Bharat Serums and Vaccines BSV team, I thank everyone here. First of all, Dr. Rajana Khanna ma'am, it's an honor to have a senior doctor like you on this platform and addressing the audience and talking about the intrapartum care. It was actually a knowledge feast, I can say, to all our delegates. And I also take this opportunity to thank those doctors who have joined today, even in their busy schedule, after a long weekend of Christmas. And I also thank Dr. Anudita from BSV team and our technical partner, RX Events. And I also take this opportunity to thank each and everyone, those who have joined here. And once again, we'll come up with new interesting topics and informative topics very soon in coming days. So all your supports are required as you have supported today. Thank you, ma'am. Thanks a lot.
Thank you, ma'am.
Thank you.